So priorities, I think, are number one, joining everything up. I think everybody agrees with us when we say that primary care, secondary care, patients are moving between them fast, quicker, and care is being shared much more between community and hospitals, acutes and mental health. So we need to join the different systems up. So I think that's the first priority. And then I think the second priority is making better use of data. At the moment, so much of patient data is on paper, where it's out of the reach of data analytics, it's out of the reach of fast auditing. And actually, if we're ever going to improve health service and we're ever going to institute change at the care level, you need access to that data to be able to audit and find improvements. So I think they're your main priorities. How the industry can do better, I think we need to really draw on the lessons of the national programme for IT. There wasn't much that the £12.7 billion programme delivered us that was good. Not very many people will come out on record and say that, but I think it was pretty much a failure. We were meant to get an electronic patient record. We ended up with something that was half built and went into a minority of trusts and was very expensive to maintain the contracts for. We were meant to get electronic prescribing very early on. It was late and was only used in a minority of GP practice up until very recently. And I think the central problem there was that we had this centrist approach of there were some darling companies that were picked. They were going to be the ones involved, and clinicians were never courted for their opinion until very late on. I think they're the mistakes that need to be avoided, and this time round it needs to be more bottom up. It needs to be doctors and nurses driving the agenda, saying what they want from their IT solution. It needs to be a new age of vendors who are responsive to the frontline staff, who implement those suggestions quickly, and most importantly are able to iteratively improve their solutions as time goes on, not just freezing software in stasis for 10 years. And I think then we need a culture in NHS trusts that embraces new ideas. At the moment, there's very much a habit of saying, oh, if it's not already deployed in loads of different trusts, I don't want to touch it because it's not tried and tested. But tried and tested means no one innovates, and we need to change that. We need to make a much more pro R&D environment. So they're the main things. I mean, there's different facets of a paper-free NHS. There's obviously bits that face managers and people who purchase and organise healthcare. So, you know, there's being able to look at data and seeing how many patients my hospital's seeing. There's bits that face the doctors and nurses, such as what's happening to this patient, who last saw them, what did they think, what's the care plan? And there is an ever-evolving, emerging, patient-facing side of what's happening to me next, who do I contact about this problem, what was my last test result. So I think those three things need to be catered for. To give you an example of how I think it should be done, the big paper manila folders that we carry around in trolleys on wards, they obviously have been a mainstay of medicine for many years, but they've got big problems. They don't allow two people to access the data at once. They can be illegible. Things go missing all the time. I've personally had clinics with patients where I haven't had their notes to hand. The first thing that paperless NHS will provide is the ability to slay all those problems and be able to get multiple people access to data at the same time. No matter where the patient is, you've got their data to hand, etc. I envisage a system where you log in once, you can access it on any device that you've got, having logged in securely. You can view the patient's past medical history, their current episode, their full clinical noting. You have diagrams, you can electronically prescribe, you look at their vitals, you can book tests, you can view results, you can send off discharge letters, and when you hand over your care to the next person down the chain, be that in the hospital or in a different care organisation, they get that full rich data and are able to continue where they left off, all through whatever device they want to use. So I actually wear two hats here today. So I'm both a innovator in the NHS and a clinician. Now I have a company which develops electronic medical record solutions, and the reason I set it up was because I realised I couldn't make change from the inside, from the NHS. I had to come in from the outside. But then coming in from the outside, I found that often we were being ignored because we were a small new organisation. What we're able to do here today is have direct contact with the people who are the decision makers in NHS trusts, and similarly us clinicians are able to speak directly to vendors and say, actually, clinical input's really important. You've got to design clinician input from day one of developing your solution, not rubber stamp your solution at the end. And so two ways: vendors get to hear from clinicians how to build a solution, and clinicians get to talk directly to vendors, and vendors can access the key decision makers. That's a massive benefit for both parties.